Hello everyone, welcome to this video on high yield concepts in radiology. Today we're going to be discussing GI bleed scans, specifically in nuclear medicine. So gastrointestinal bleed scans are a non-invasive diagnostic imaging study used to identify sources of gastrointestinal bleeds. They utilize radionuclide imaging and they involve low radiation exposure. They're usually not the first line of choice of diagnosis. They're indicated in specific clinical scenarios. They're used to identify sources of obscure bleed or intermittent bleed, and they're usually ordered by surgeons or interventional radiologists for pre-procedural planning. The advantages they offer is they allow for detection of rates down to 0.1 milliliters a minute. They also allow for continuous imaging. This is a huge advantage over something like a CT scan, which involves imaging at a specific point in time. Bleed scans kind of follow with the 60-minute frame, or they can also be used up to 8 hours, depending on the clinical judgment. So this is really good to identify sources of bleed that might be intermittent or obscure places. So they utilize a single photon emitter technetium-99 labeled red blood cells. So the patient comes in, usually no prep is needed, as opposed to something like a colonoscopy. And the patient comes in, 3 milliliters of their blood is drawn and mixed with 25 units of technetium. This is now injected back into the patient. This is known as the in vitro method, and it's usually preferred over the in vivo method, which involves injecting technetium into the bloodstream. This usually leads to suboptimal labeling because of free technetium dispersed throughout, and the in vitro method is what's usually preferred. And usually 60 minutes of imaging is conducted clinically. So in order for it to be classified as a GI bleed, it has to meet the criteria, which involves 3 different things. So number 1, there has to be increase in the intensity of radionuclide activity over time. Number 2 is movement of the radionuclide activity, which confirms the lumen of the bowel. And number 3, identification of radionuclide activity outside of the expected structures. The last one is really important because you want to be able to distinguish the expected structures from something that is abnormal. And for example, in certain cases, there can be genital blood pooling, which can lead to increased radionuclide activity, and this can sometimes be misinterpreted as rectal bleeds or bleed in the large bowel. So it's really important to distinguish this. So in imaging, it's important to know that there's very low resolution but high sensitivity, as we can see over here. So we can kind of see the liver and the spleen over here, and then the aorta coming down, and then the common iliac bifurcating over here. And there's general patterns to look out for. Again, these are very general patterns. So in the small bowel, if there's rapid curvilinear movement or a central location, it's likely a small bowel bleed, versus a large bowel bleed, which will have a more of a linear pattern, it's peripherally located, or sometimes an S pattern, which can be indicative of rectosigmoid distribution. Okay, so this is an example of a GI bleed scan, and we'd start off by looking at the frames over times. Usually over a 60-minute time span, all the frames are kind of collected and a short little video is created. In this case, all the frames are laid out every 2 minutes apart, and what we're looking for is things that meet the criteria we discussed earlier, the 3 aspects of the criteria. First of all, the increased intensity of radionuclide activity over time, which confirms the lumen of the bowel and identified outside of expected structures. So again, we kind of see everything looks okay up until about 20-minute mark. We start to see increased intensity of the radionuclide activity over here, and we kind of see how it increases over time, which meets the criteria. This is also identified outside of expected structures. You would not see this in a normal GI bleed scan, and it confirms the lumen of the bowel. So looking at this pattern, this is likely a large bowel bleed because it's peripherally identified. Small bowel bleeds would be more central, have sometimes a curvilinear pattern. So this is a large bowel bleed. And again, you're looking for things that identify all 3 criteria. And we can see how there's increased uptake over time over here. And again, very low resolution, but extremely high sensitivity in the GI bleed scans. So again, we start from the top over here, and we look at how these frames are laid out every 2 minutes apart. We're looking for something that meets the criteria that we discussed earlier. So this is the liver, and then the aorta, and then the common iliac. Everything appears to be normal so far in all these frames. And then at the 40-minute frame, we can see how there's increased intensity right over here, and it further increases. So this meets our criteria, There's increased intensity over time, which confirms the lumen of the bowel and outside of the expected structures. So this will be classified as a GI bleed. Now, the location is in the small bowel because it's more centrally located, and it also has this S pattern right here. So this is indicative of going small bowel bleeding into the rectosigmoid junction, as we can see over here. So this scan was also stopped at 44 minutes, and the patient was rushed to interventional radiology because they identified the source of the bleed, and there was no point in conducting further imaging. I hope this video was helpful, and thank you guys for watching.